Lewis's Medical Surgical Nursing, 11th edition, Chapter 47, Assessment, Endocrine System. Structures and functions of endocrine system. Glands. Endocrine glands include the hypothalamus, pituitary, thyroid, parathyroids, adrenals, pancreas, ovaries, testes, and pineal gland. These glands make and release special chemical messengers called hormones. The endocrine system has 5 general functions. 1. A role in reproductive and central nervous system (CNS) development in the fetus. 2. Stimulating growth and development during childhood and adolescence. 3. Sexual reproduction. 4. Maintaining homeostasis. And 5. Responding to emergency demands. Hormones. Hormones are chemical substances made by endocrine glands that control and regulate the activity of certain target cells or organs. Many are made in one part of the body and control and regulate the activity of certain cells or organs in another part of the body. The thyroid gland makes the hormone thyroxine, which affects many body tissues when released directly into the circulation. Other hormones act locally on cells where they are released and never enter the bloodstream. We call this local effect paracrine action. The action of sex steroids on the ovary is an example of paracrine action. Most hormones have common characteristics, including 1. Secretion in small amounts at variable but predictable rates. 2. Regulation by feedback systems. And 3. Ability to bind to specific target cell receptors. There is a strong connection between the endocrine system and nervous system. Catecholamines, e.g. epinephrine, secreted by the adrenal gland, travel through the bloodstream and affect multiple organ systems. These same substances, when secreted by nerve cells in the brain and peripheral nervous system, act as neurotransmitters, sending important impulses across nerve synapses. Organs can act as endocrine glands by secreting hormones. For example, the kidneys secrete erythropoietin, a substance that stimulates red blood cell production. The heart secretes atrial natriuretic peptide, ANP. The GI tract secretes many peptide hormones, e.g. gastrin, that aid in digestion. These hormones are discussed in the respective assessment chapters. Hormone receptors. Hormones exert their effects by recognizing their target tissues and attaching to receptor sites in a lock and key type of mechanism. This means a hormone will act only on cells that have a receptor specific for that hormone. Lipid-soluble and water-soluble hormones. We classify hormones by their chemical structures as either lipid-soluble or water-soluble. The differences in solubility becomes important in understanding how the hormone interacts with the target cell. Lipid-soluble hormones, steroids, thyroid, are bound to plasma proteins as they travel to target cells. They cross the cell membrane by simple diffusion. Water-soluble hormones, insulin, growth hormone, prolactin, circulate freely in the blood and act directly on target tissues. Regulation of hormonal secretion. Specific mechanisms control endocrine activity by either stimulating or inhibiting hormone synthesis and secretion. These include positive and negative feedback, nervous system control, and physiologic rhythms. Simple feedback. Negative feedback relies on the blood level of a hormone or other chemical compound regulated by the hormone, e.g. glucose. It is the most common type of endocrine feedback system. It results in the gland increasing or decreasing the release of a hormone. Negative feedback functions like a thermostat. Cold air in a room activates the thermostat to release heat. Warm air signals the thermostat to turn off the heater. An example of negative feedback is calcium and parathyroid hormone, PTH, regulation. Low blood levels of calcium stimulate the release of PTH from the parathyroid gland. PTH acts on the bone, intestine, and kidneys to increase blood calcium levels. The increased blood calcium level then inhibits further PTH release. With positive feedback, increasing hormone levels cause another gland to release a hormone that then stimulates further release of the first hormone. Something must stop the release of the first hormone, e.g., follicle death, or its release will continue. The ovarian hormone, estradiol, works by this type of feedback. Increased levels of estradiol made by the follicle during the menstrual cycle result in the production and release of follicle-stimulating hormone, FSH, by the anterior pituitary. FSH causes further increases in estradiol until the death of the follicle. This results in a drop of FSH serum levels. Nervous system control. Nervous system activity directly affects some endocrine glands. Pain, fear, sexual excitement, and other stressors can stimulate the nervous system to control hormone secretion. For example, when the CNS senses or perceives stress, the sympathetic nervous system, SNS, secretes catecholamines, e.g., epinephrine, which maximize heart and lung function and vision to deal with the stress more effectively. Chronic exposure to some stressors can cause persistent increases in heart rate and BP and changes in the endocrine system. This puts patients at risk for chronic disease such as hypertension and heart disease. Stress-related effects are discussed in Chapter 6. Rhythms. A common physiologic rhythm is the circadian rhythm. It is a 24-hour rhythm that is driven by sleep-wake or dark-light 24-hour diurnal cycles. Hormone levels and the responsiveness of target tissues fluctuate predictably during these cycles. Cortisol made by the adrenal cortex rises early in the day, declines toward evening, and rises again toward the end of sleep to peak by morning. Growth hormone, thyroid stimulating hormone, and prolactin levels peak during sleep. Reproductive cycles are often longer than 24 hours. Ultradian. An example is the menstrual cycle. These rhythms are important to consider when interpreting laboratory results for hormone levels. Hypothalamus. Although many refer to the pituitary gland as the master gland of the endocrine system, most of its functions rely on its interrelationship with the hypothalamus, which lies next to the pituitary gland. The hypothalamus releases substances that either stimulate or inhibit the production and release of hormones from the pituitary gland. Examples of these hormones include corticotropin-releasing hormone and thyrotropin-releasing hormone. Somatostatin inhibits growth hormone release. Neurons in the hypothalamus receive input from the CNS, including the brainstem, limbic system, and cerebral cortex. These neurons create a circuit that helps coordinate the endocrine system and autonomic nervous system, ANS. The hypothalamus also coordinates the expression of complex behavioral responses, such as anger, fear, and pleasure. Pituitary. The pituitary gland, hypophysis, is in the sella turcica under the hypothalamus at the base of the brain above the sphenoid bone. The infundibular hypophyseal stalk connects the pituitary and hypothalamus. This stalk relays information between the hypothalamus and pituitary, creating a strong neuroendocrine connection. The pituitary consists of two major parts: the anterior lobe, adenohypophysis, and posterior lobe, neurohypophysis. A smaller intermediate lobe makes melanocyte stimulating hormone, MSH. Anterior pituitary. The anterior lobe of the pituitary accounts for 80% of the gland by weight. The hypothalamus regulates the anterior lobe through releasing and inhibiting hormones. These hypothalamic hormones reach the anterior pituitary through a network of capillaries known as the hypothalamus hypophyseal portal system. These releasing and inhibiting hormones, in turn, affect the secretion of 6 hormones from the anterior pituitary. We refer to several hormones secreted by the anterior pituitary as tropic hormones. Tropic hormones control the secretion of hormones by other glands. Thyroid stimulating hormone, TSH, stimulates the thyroid gland to secrete thyroid hormones. Adrenocorticotropic hormone, ACTH, stimulates the adrenal cortex to secrete corticosteroids. FSH stimulates secretion of estrogen and the development of ova in women and sperm in men. Luteinizing hormone, LH, stimulates ovulation in women and secretion of sex hormones in both men and women. Growth hormone, GH, affects the growth and development of all body tissues. It has many biologic actions, including a role in protein, fat, and carbohydrate metabolism. Prolactin, or lactogenic hormone, stimulates the breast development needed for lactation after childbirth. Posterior pituitary. The posterior pituitary is composed of nerve tissue and is essentially an extension of the hypothalamus. Communication between the hypothalamus and posterior pituitary occurs through nerve tracts. The hormones secreted by the posterior pituitary, antidiuretic hormone, ADH, and oxytocin, are made in the hypothalamus. These hormones travel down the nerve tract from the hypothalamus to the posterior pituitary and are stored there until stimuli trigger their release. The major physiologic role of ADH, also called arginine vasopressin, is to regulate fluid volume. It causes the renal tubules to reabsorb water, making the urine more concentrated. A rise in plasma osmolality or hypovolemia causes specialized neurons in the hypothalamus, known as osmoreceptors, to stimulate ADH release from the posterior pituitary. When ADH release is inhibited, renal tubules do not reabsorb water, resulting in more dilute urine. Volume receptors in large veins, heart atria, and carotid arteries that sense pressure changes from hypovolemia also contribute to ADH control. ADH is also a potent vasoconstrictor. Pineal gland. The pineal gland is in the brain. It is composed of photoreceptive cells. Its primary function is the secretion of the hormone melatonin. Melatonin secretion increases in response to exposure to the dark and decreases in response to light exposure. The gland helps to regulate circadian rhythms and reproductive system at the onset of puberty. Thyroid gland. The thyroid gland is in the anterior part of the neck in front of the trachea. It consists of two encapsulated lateral lobes connected by a narrow isthmus. The thyroid gland is highly vascular. Its size is related to TSH secretion by the anterior pituitary. The three hormones made and secreted by the thyroid gland are thyroxine, T4, triiodothyronine, T3, and calcitonin. Thyroxine and triiodothyronine. Thyroxine T4 accounts for 90% of thyroid hormone made by the thyroid gland. However, triiodothyronine T3 is much more potent and has greater metabolic effects. The thyroid gland directly secretes about 20% of circulating T3. The rest comes from the conversion of T4 after its release into the bloodstream. Iodine is required for the synthesis of both T3 and T4. Both hormones affect metabolic rate, caloric requirements, O2 consumption, carbohydrate and lipid metabolism, growth and development, brain function, and other nervous system activities. More than 99% of thyroid hormones are bound to plasma proteins, especially thyroxine-binding globulin made by the liver. Only the unbound, free hormones are biologically active. TSH from the anterior pituitary gland stimulates thyroid hormone production and release. When circulating levels of thyroid hormone are low, the hypothalamus releases thyrotropin-releasing hormone, TRH. TRH causes the anterior pituitary to release TSH. High circulating thyroid hormone levels inhibit the secretion of both TRH from the hypothalamus and TSH from the anterior pituitary gland. Calcitonin. Calcitonin is made by C cells, parafollicular cells, of the thyroid gland in response to high circulating calcium levels. Calcitonin lowers serum calcium levels by 1. Inhibiting the transfer of calcium from the bone to blood, 2. Increasing calcium storage in bone, and 3. Increasing renal excretion of calcium and phosphorus. Calcitonin and PTH regulate calcium balance. Parathyroid glands. There are usually two pairs of parathyroid glands lying behind each thyroid lobe. Although there are usually 4 glands, their number may range from 2 to 6. Parathyroid hormone. The parathyroid glands secrete parathyroid hormone, PTH, also called parathormone. Its major role is to regulate serum calcium levels. PTH increases serum calcium levels by acting on bone, the kidneys, and indirectly on the GI tract. PTH stimulates the transfer of calcium from the bone into the blood. In the kidney, PTH promotes calcium reabsorption, moving calcium from the renal tubules back into the bloodstream, and phosphate excretion. PTH stimulates the renal conversion of vitamin D to its most active form, 1,25 dihydroxyvitamin D3. This form of vitamin D promotes calcium and phosphorus absorption in the GI tract. PTH secretion is regulated by a negative feedback system. When serum calcium or magnesium levels are low, PTH secretion increases. When serum calcium or active vitamin D levels are high, PTH secretion falls. Adrenal glands. The adrenal glands are small, paired, highly vascular glands located on the upper part of each kidney. Each gland consists of two parts, medulla and cortex. Each part has distinct functions and act independently from the other. Adrenal medulla. The adrenal medulla is the inner part of the adrenal gland. It consists of sympathetic postganglionic neurons. The medulla secretes the catecholamines, epinephrine, adrenaline, norepinephrine, noradrenaline, and dopamine. We consider catecholamines neurotransmitters when they are secreted by neurons, and hormones when they are secreted by the adrenal medulla. They are an essential part of the SNS's fight or flight response. Adrenal cortex. The adrenal cortex is the outer part of the adrenal gland. It secretes several steroid hormones, including glucocorticoids, mineralocorticoids, and androgens. Cholesterol is the precursor for steroid hormone synthesis. Glucocorticoids, e.g. cortisol, are named for their effects on glucose metabolism. They inhibit the inflammatory response and are considered anti-inflammatory. Mineralocorticoids, e.g. aldosterone, are essential for maintaining fluid and electrolyte balance. The term corticosteroid refers to both glucocorticoids and mineralocorticoids. Cortisol. Cortisol, the most abundant and potent glucocorticoid, is necessary to maintain life and protect the body from stress. It is secreted in a diurnal pattern. A negative feedback mechanism controls cortisol secretion. The release of corticotropin-releasing hormone, CRH, from the hypothalamus stimulates the secretion of ACTH by the anterior pituitary. A major function of cortisol is regulating blood glucose concentration by stimulating hepatic glucose formation. Gluconeogenesis. Cortisol inhibits peripheral glucose use in the fasting state, inhibits protein synthesis, and stimulates the mobilization of glycerol and free fatty acids. It helps maintain vascular integrity and fluid volume through its action on mineralocorticoid receptors. Cortisol decreases the inflammatory response by stabilizing the membranes of cellular lysosomes and preventing increased capillary permeability. Stress, burns, infection, fever, acute anxiety, and hypoglycemia increase cortisol levels. Aldosterone. Aldosterone is a potent mineralocorticoid that maintains extracellular fluid volume. It acts on the renal tubule to promote renal reabsorption of sodium and excretion of potassium and hydrogen ions. Hyponatremia, hyperkalemia, and angiotensin II stimulate aldosterone synthesis and secretion. ANP and hypokalemia inhibit aldosterone synthesis and release. Adrenal androgens. The adrenal cortex secretes small amounts of androgens. They are converted to sex steroids in peripheral tissue. Testosterone in men and estrogen in women. The most common adrenal androgens are dihydroepiandrosterone, DHEA, and androstenedione. Because they are precursors to other sex steroids, their actions are like those of testosterone and estrogen. In postmenopausal women, the major source of estrogen is the peripheral conversion of adrenal androgens to estrogen. Pancreas. The pancreas is a long, tapered, lobular, soft gland located behind the stomach and anterior to the first and second lumbar vertebrae. The pancreas has both exocrine and endocrine functions. The hormone secreting part of the pancreas is the islets of Langerhans. The islets account for less than 2% of the gland. They consist of four types of hormone secreting cells: alpha, beta, delta, and F cells. The alpha cells make and secrete the hormone glucagon. The beta cells make and secrete insulin and amylin. Delta cells make and secrete somatostatin. F or PP cells secrete pancreatic polypeptide. Glucagon. Pancreatic alpha cells release glucagon in response to low blood glucose levels, protein ingestion, and exercise. Glucagon increases blood glucose, providing fuel for energy by stimulating glycogenolysis, breakdown of glycogen into glucose, gluconeogenesis, formation of glucose from non-carbohydrate molecules, and ketogenesis. Glucagon and insulin function in a reciprocal manner to maintain normal blood glucose levels. Insulin. Insulin is the main regulator of metabolism and storage of ingested carbohydrates, fats, and proteins. Insulin facilitates glucose transport into cells, transport of amino acids across muscle membranes, and the synthesis of amino acids into protein in the peripheral tissues. However, the brain, nerves, lens of the eye, hepatocytes, erythrocytes, and cells in the intestinal mucosa and kidney tubules are not dependent on insulin for glucose uptake. After a meal, insulin is responsible for how we use and store nutrients, anabolism. An increased blood glucose level is the major stimulus for insulin synthesis and secretion. Low blood glucose levels, glucagon, somatostatin, hypokalemia, and catecholamines usually inhibit insulin secretion. Gerontologic considerations. Effect of aging on endocrine system. Normal aging has many effects on the endocrine system. Table 47.3. These include 1. Decreased hormone production and secretion. 2. Altered hormone metabolism and biologic activity. 3. Decreased responsiveness of target tissues to hormones. And 4. Changes in circadian rhythms. Assessing the effects of aging on the endocrine system may be difficult because the subtle changes of aging may mimic manifestations of endocrine disorders. Endocrine problems may manifest differently in an older adult than in a younger person. Older adults may have multiple comorbidities and take medications that change the body's usual response to endocrine function. Symptoms of endocrine problems, such as fatigue, constipation, or mental impairment, may be attributed to aging, resulting in delayed treatment. Assessment of endocrine system. Endocrine problems generally result from too much or too little of a specific hormone. The onset of symptoms is often gradual. Subtle or vague symptoms are often attributed to other physiologic or psychologic causes. Patients may present with fluid and electrolyte imbalances, altered tissue perfusion, inadequate coping mechanisms, changes in heart rhythm, or changes in skin integrity that can be interpreted as many other conditions. Alternatively, patients may present with acute symptoms that are life-threatening and demand immediate intervention. Subjective data. Information obtained from the patient can provide important clues as to the functioning of the endocrine system. You will need to obtain a thorough history from the patient and/or a caregiver if the patient's mental acuity is compromised. Important health information. Past health history. Patients with endocrine disorders often present with nonspecific complaints. The chief complaint may relate to not just one, but a group of symptoms. The most common presenting problems include fatigue, weakness, menstrual irregularities, and weight changes. It is important to determine if the onset of symptoms has been gradual or sudden and what the patient has done about them. Because some of the more general signs of problems are the easiest to overlook, you must evaluate any reported or observed changes in weight, appetite, skin, libido, mental acuity, emotional stability, or energy levels. Medications. Ask about the use of all medications, both prescription and over-the-counter, herbs, and dietary supplements. Ask about the reason for taking the drug, the dosage, and the length of time the drug has been taken. In particular, ask about the use of hormone replacements. Knowing that the patient is currently taking hormone replacements, such as insulin, thyroid hormone, or corticosteroids, e.g. prednisone, should alert you to potential adverse drug events. For example, corticosteroids may increase blood glucose levels and cause bone loss with long-term use. Thyroid preparations may cause tachycardia or dysrhythmias. Drug-to-drug interactions and adverse effects of non-hormonal medications can contribute to endocrine problems. Surgery or other treatments. Ask about past medical, surgical, and obstetric history, including number of pregnancies and live births. Assess growth patterns and stages of physical and emotional development. For example, knowing about radiation therapy to the head and neck is important when you suspect thyroid or pituitary problems. Functional health patterns. Key questions to ask the patient with an endocrine problem are outlined in Table 47.4. Health perception, health management pattern. Heredity plays a key role in the development of endocrine problems. Ask about first-degree relatives with diabetes, thyroid disease, or endocrine gland cancers, since these conditions have a familial tendency. A genetic assessment of family members may be needed. Nutritional metabolic pattern. Changes in appetite and weight can indicate an endocrine problem. Ask about a history of weight distribution and changes. Weight loss with increased appetite may occur with hyperthyroidism or diabetes. Weight gain may occur with hypothyroidism or hypocortisolism. Obese persons are more likely to develop type 2 diabetes. Ask if there have been problems with nausea, vomiting, or diarrhea. An enlarged thyroid gland can cause difficulty swallowing or a change in neck size. Increased SNS activity, including nervousness, palpitations, sweating, and tremors, may occur with thyroid problems or a rare tumor of the adrenal medulla. Pheochromocytoma. Heat or cold intolerance occur with hyperthyroidism or hypothyroidism, respectively. Ask about changes in the patient's skin, especially on the face, neck, hands, or body creases. Changes in skin texture and skin that seems thicker or drier may suggest an endocrine problem. A patient with hypothyroidism or excess GH may have skin that feels coarse or leathery. Ask if the patient has noticed any change in the distribution of hair anywhere on the body. Elimination pattern. Because maintaining fluid balance is a major role of the endocrine system, questions related to fluid intake and elimination patterns may uncover endocrine problems. For example, increased thirst and urination can indicate diabetes, pancreas disorder, or diabetes insipidus, pituitary disorder. Ask about the frequency and consistency of bowel movements. Diarrhea can occur with hyperthyroidism or thyroid cancer. Constipation occurs with hypothyroidism, hypoparathyroidism, and hypopituitarism. Activity exercise pattern. Determine if there are any acute or gradual changes in energy level or persistent fatigue. A patient with chronic fatigue secondary to hypothyroidism, hypocortisolism, or diabetes may report changes in activity level. Sleep rest pattern. Ask the patient how many hours they typically sleep and if they feel rested on awakening. Sleep problems can result in nocturia, nightmares, anxiety, depression, or insomnia that occur with diabetes or thyroid problems. Cognitive perceptual pattern. Memory deficits may occur with hypothyroidism and changes in sodium levels. Inappropriate secretion of antidiuretic hormone, SIADH, or pituitary tumors can cause hyponatremia. These issues can occur gradually. Gathering information from patient and family about memory, cognitive abilities, and balance can increase the chances of an earlier diagnosis. Self-perception, self-concept pattern. Many endocrine disorders may affect a patient's self-esteem because of associated changes in physical appearance. For example, weight gain associated with hypothyroidism or exophthalmos and goiter associated with hyperthyroidism can cause problems related to body image. Role relationship pattern. Questions related to roles and relationships can highlight depression, chronic fatigue, and sleep problems. With chronic fatigue, depression, and anxiety, patients and their families will have stressed relationships. Questions related to home life and the patient's ability to fulfill their role in the family will aid in identifying problems. Sexuality reproductive pattern. The endocrine system regulates GH, prolactin, LH, FSH, testosterone, and estrogen. Therefore, menstrual problems, hirsutism, infertility, decreased libido, and growth disorders can be a result of endocrine disorders. Some women develop hypothyroidism during or after menopause. Other patients begin to develop type 2 diabetes during middle age when sex hormones are changing. Document the presence of abnormal secondary sex characteristics such as facial hair, hirsutism, in women. Obtain a detailed history of menstruation and pregnancy. Menstrual problems can occur with disorders of the ovaries and pituitary, thyroid, and adrenal glands. A history of large birth weight babies or gestational diabetes increases the risk for developing type 2 diabetes later in life. Male sexual problems may include impotence, infertility, or the lack of development of secondary sexual characteristics. Retrograde ejaculation can occur in diabetes. Coping stress tolerance pattern. Because stress worsens some endocrine conditions, ask patients about their stress level and usual coping patterns. Patients with adrenal insufficiency have difficulty dealing with stress. These patients are at risk for developing hypotension and fluid and electrolyte imbalance. Value belief pattern. Determining a patient's ability to make lifestyle changes is an important nursing function. Identify the patient's value belief patterns so that you can help to determine appropriate treatment plans. This is especially important in a condition such as diabetes, which may require major lifestyle changes. Other disorders, such as hypothyroidism or hypocortisolism, may be managed with medications but need lifelong monitoring. Objective data. Except the thyroid and testes, most endocrine glands are inaccessible to direct examination. Assessment can be accomplished using objective data from the physical examination and diagnostic tests. It is essential to understand the actions of hormones in order to assess the function of a gland by monitoring the target tissue. Physical examination. Use the following general examination when evaluating endocrine function. Specific clinical findings from the various endocrine problems are discussed in chapters 48 and 49. Endocrine disorders may cause changes in mental and emotional status. Throughout the examination, assess the patient's orientation, alertness, memory, cognitive abilities, affect, personality, and appropriateness of their behavior. Take a full set of vital signs at the beginning of the examination. Variations in temperature, heart rate, and BP can occur with a variety of endocrine-related problems. Obtain height and weight. Calculate BMI to assess nutritional status. Integument. Assess the color and texture of the skin, hair, and nails. Note the overall skin color as well as pigmentation and bruising. Decreased skin pigmentation can occur in hypopituitarism, hypothyroidism, and hypoparathyroidism. Hyperpigmentation, or bronzing of the skin, especially on knuckles, elbows, knees, genitalia, and palmar creases, is a classic finding in a form of adrenal insufficiency known as Addison's disease. Palpate the skin for texture and moisture. Examine hair distribution on the head, face, trunk, and extremities. Assess the hair's appearance and texture. Hair loss, excess hair growth, or dull, brittle hair may suggest endocrine problems. Assess for delayed wound healing. Head. Inspect the size and contour of the head. Facial features should be symmetric. Hyperreflexia and facial muscle contraction upon percussion of the facial nerve, Chvostek's sign, may occur in hypoparathyroidism. Inspect the eyes for position, symmetry, and shape. Large and protruding eyes, exophthalmos, are associated with hyperthyroidism. Assess visual acuity using a Snellen eye chart. Visual field loss may occur with a pituitary tumor. In the mouth, inspect the buccal mucosa, condition of teeth, and tongue size. Note hair distribution on the scalp and face. Hearing loss is common in acromegaly from excess GH. Neck. The thyroid gland is not usually visible during inspection. A feature that distinguishes the thyroid from other masses in the neck is its upward movement on swallowing. Inspect the neck while the patient swallows a sip of water. The neck should appear symmetric without lumps or bulging. Palpate the thyroid for its size, shape, symmetry, and tenderness, and for any nodules. Goiter, an enlarged thyroid gland, can occur with hyperthyroidism or hypothyroidism. Be careful not to press too hard or massage an enlarged thyroid gland. This can cause a sudden release of thyroid hormone into an already overloaded system. An experienced clinician should perform palpation in patients with a known diagnosis of hyperthyroidism. Perform palpation using a posterior or anterior approach. For anterior palpation, stand in front of the patient with the patient's neck flexed. Place your thumb horizontally with the upper edge along the lower border of the cricoid cartilage. Then, move your thumb over the isthmus as the patient swallows water. Place your fingers laterally to the anterior border of the sternocleidomastoid muscle and palpate each lateral lobe before and while the patient swallows water. For posterior palpation, stand behind the patient with the thumbs of both hands resting on the nape of the patient's neck. Use your index and middle fingers of both hands to feel for the thyroid isthmus and for the anterior surfaces of the lateral lobes. To relax the neck muscles, Ask the patient to flex the neck slightly forward and to the right. Displace the thyroid cartilage to the right with your left hand and fingers. Palpate with your right hand after placing the thumb deep and behind the SCM muscle with the index and middle fingers in front of it. Ask the patient to swallow water and feel for the thyroid to move up. In a normal person, the thyroid is often not palpable. If palpable, it usually feels smooth with a firm consistency. It is not tender with gentle pressure. If nodules, enlargement, asymmetry, or hardness, abnormal findings, are present, refer the patient for further evaluation. Auscultate the lateral lobes of an enlarged thyroid gland with the stethoscope bell to hear a bruit, a soft swishing sound that can occur with a goiter or hyperthyroidism. Thorax. Inspect the thorax for shape and characteristics of the skin. Note the presence of breast gynecomastia in men. Auscultate lung sounds and heart sounds. Note any adventitious lung sounds, wheezing, decreased sounds, or extra heart sounds. Signs of fluid overload or heart failure may be present in patients with SIADH or hypothyroidism. Abdomen. Inspect the contour of the abdomen and note the symmetry and color. Cushing syndrome, hypercortisolism, causes the skin to be fragile, resulting in purple-blue striae across the abdomen. Note general obesity or truncal obesity. Auscultate bowel sounds. Extremities. Assess the size, shape, symmetry, and general proportion of hands and feet. Patients with acromegaly from pituitary tumors may have large hands and feet. Inspect the skin for changes in pigmentation, lesions, and edema. Assess muscle strength and deep tendon reflexes. In the upper extremities, assess for tremors by placing a piece of paper on the outstretched fingers, palm down. Muscular spasms of the hand, elicited on application of an occlusive BP cuff for 3 minutes, Trousseau's sign, may occur in hypoparathyroidism. Genitalia. Inspect the genital hair distribution pattern, since it may be changed with hormone problems. Diagnostic studies of endocrine system. Pertinent findings from the history and physical examination guide the selection of diagnostic studies. Imaging studies can identify pituitary tumors, thyroid nodules, or adrenal tumors. Laboratory studies may include direct measurement of the hormone level or an indirect measure of gland function by evaluating blood or urine components affected by the hormone, such as glucose or electrolytes. We can also measure the releasing or stimulating hormone. For example, we can evaluate thyroid function by measuring TSH. We can assess hormones with constant basal levels, such as T4, with a single measurement. Note the time of the sample collection on the laboratory slip. Information about night shift work is important for hormones with circadian or sleep-related secretion, e.g., cortisol. Evaluating other hormones may require multiple blood samplings, such as in suppression tests, e.g., dexamethasone, and stimulation tests, e.g., glucose tolerance. In these situations, it is often necessary to obtain IV access to give the testing medication and fluids and draw multiple blood samples. Pituitary gland problems can manifest in a wide variety of ways because of the number of hormones produced. Many diagnostic studies evaluate these hormones either directly or indirectly. Several tests are available to evaluate thyroid function. The most sensitive and accurate laboratory test is the measurement of TSH. Thus, it is often the first diagnostic test done to evaluate thyroid function. Follow-up tests ordered when the TSH level is abnormal include total T4, free T4, and total T3. Free T4 is the unbound thyroxine and more accurately reflects thyroid function than total T4. The only hormone secreted by the parathyroid glands is PTH. Because PTH regulates serum calcium and phosphate levels, these levels reflect abnormalities in PTH secretion. For this reason, diagnostic tests for the parathyroid gland typically include PTH, serum calcium, and serum phosphate levels. Tests associated with the adrenal cortex function focus on measuring blood plasma and urine levels of the three types of hormones secreted: glucocorticoids, mineralocorticoids, and androgens. Urine studies often require a 24-hour urine collection to eliminate the impact of short-term fluctuations in plasma hormone levels. The tests used to evaluate glucose metabolism are important in the diagnosis and management of diabetes.